Hello everyone and welcome. Thank you for joining us in the salon. So my name is Dr. Sam Moxon. I am a research fellow at the University of Birmingham and I'm delighted to be guest hosting today's salon meeting, which explores the latest advancements in drugs for dementia. Now this is particularly pertinent because we saw headlines yesterday about rising rates of dementia. So this is going to be really interesting to have this discussion. And as you probably know, these salon sessions are sort of a new type of gathering. So what we're trying to do is explore research and career topics to get some new perspectives and to hopefully educate, entertain, and drive change. So we're going to start with a live stream that includes some thought-provoking and informative talks from two great speakers, and they're each going to have a unique take on this topic. Then we'll have a short discussion, and we can spend the rest of the time letting you guys join in the chat, share your thoughts, ask questions. So we'll start with some instructions. We've got two speakers. We've got Aisha Amjad and Dr. Amanda Helsgrave. So hi both, how are you doing?
Hello, good, hi, thank you, nice to be here.
Yeah, good, yes. Thanks for joining us. So Amanda is co-lead of the Fluid Biomarker Lab and the Biomarker Factory in the UK DRI, Dementia Research Institute at University College London. And Amanda works with Professor Henrik Zetterberg, researching biomarkers for neurodegenerative diseases. And as we all know, blood biomarkers have been seen as a key element to support delivery of new treatments. And this is a major focus of Amanda's work. And Aisha is a pharmacist and has recently completed a master's in pharmacology and drug discovery from Coventry University. So before we get into it, I think we should just take a couple of seconds to set the scene. So recent advancements in Alzheimer's disease treatments have focused on a new class of drugs known as monoclonal antibodies. So things like Lecanemab, which is going through EU regulation at the moment. And they target amyloid plaques believed to play a critical role in disease progression. So other notable drugs are things like Donanemab, but they come with potential risks such as brain swelling, microhemorrhages, and they require careful monitoring. So their introduction into clinical practice offers hope, but also underscores the need for ongoing research to optimize safety and efficiency. So what else is on the horizon? Are these the only options we have? Or is repurposing showing progress? When will these drugs come? How do they work? And are they worth the risk? So let's hear from our speakers. And Amanda, if it's okay with you, I'd like you to go first. Could I please invite you to share your screen now?
Okay. Full screen. Okay, so when Sam said we'd be looking at this from different perspectives, he was absolutely right. I'm not actually involved in the research or the design of new drugs, but I have a real interest in it because obviously the fact that drugs are now available and on the horizon is really, really kind of accelerating the work that we have to do because we need to diagnose disease properly so that those drugs will actually have an effect. So I thought that I would take a kind of proper overview on this and just chat through what actually is in the pipeline at the moment from a wider perspective. And now, if you're in the field, maybe many of you will have seen this diagram here. There's every year, Geoffrey Cummings and his group put out a new kind of state of the field in trials for Alzheimer's disease. And I realise the title here is dementia, not just Alzheimer's disease, but this is kind of quite a nice way just to have an overview look on what's going on. Now, we can see from this chart that there's different classes of drugs and they're targeting different things. There's disease-modifying drugs, like the ones that have been recently licensed in the state, Lecanemab and Donanemab, and they actually change the course of the disease. And then there's symptom treatments, such as the symptom treatments for neuropsychiatric
Amanda,
symptoms.
sorry to jump in here, but I think there's some issues with the stream. People are saying they can't see the shared content. So could I please ask you to unshare and then reshare, and we'll see if that helps.
Apologies. Oh, I can start that again. I do apologise. I've obviously gone a bit rogue. Allow.
We can see that now. That's perfect.
You can see that now? Okay.
Yeah, I thought best catch it before we go too deep
No, no.
into the rabbit hole. So
No,
perfect. Thank you very
absolutely,
much.
because I didn't want to explain that whole thing and then find no one could see it. Right. Is that
So,
okay now?
yeah, that's perfect. Thank you. Carry on.
Right.
Thank you.
Sorry. Back now. I started explaining this, and this chart really nicely shows the different kind of drugs that are being developed, that are clinical trials. All of these dots on here indicate a trial that's happening at the moment, and they're classed into what they do. So disease modifying means that they're going to change the course of the disease, and whether that be a biologic like the monoclonal antibodies that we know have recently been licensed, or small molecules. And then there's symptomatic treatment, which will obviously alleviate symptoms and are important, especially when you think of people in the later stages of the disease. Because one thing you'll note about disease modifying drugs being developed is that they're being developed for early stage, because we know that once the disease is past a certain stage, certain level, then it's really, really hard to bring that back. And then there's also trials going on for cognitive enhancers. And I guess what we're doing here is trying to use the brain's systems, kind of not to heal itself, but to improve the connections, etc., in the brain, to help either give more resilience to getting the disease or progression of the disease, or, I mean, the ideal situation would be to cognitively enhance your way out of never getting dementia. I don't know if that will happen. But the stats, as I've just got some together, are that most of the trials going on at the moment are for disease modifying treatments, which is obviously good. And only 12% are cognitive enhancers and 13% symptomatic treatments. So if we look at the targets of the disease, there are people coming at it from different angles. Obviously, monoclonals focus on the pathogenic accumulation of amyloid in the brain. And so we can see here that at the bottom, the amyloid line is quite long. There's lots of agents being investigated in trials at the moment. And then we get neurotransmitter receptors, with lots of agents being looked at the moment. And I think that probably that's mainly small molecule diseases. But also we get inflammation and immunity, which is a real source of interest and lots of research at the moment. And those ones are also mainly biologics and small molecules. So the interesting bit, and Sam alluded to this in the beginning, is that there are 39 repurposed agents in 52 trials. I think at the moment there's a real interest in looking at drugs we're already using that already have a really good safety profile, to see if they can be used for other purposes, i.e. against dementia. And that makes up 31% of the current drugs and 32% of the current trials going on. One of the things that really interests me, maybe because I feel like in the future, if I keep on putting weight like I am now, I might need these, is GLP-1 drugs. And these drugs are, glucagon-like receptor agonists. And they're the drugs that we see in the weight loss arena, as I've said, like Ozempic and Wegovy. And there's one trial at the moment, or actually two trials going on, using semaglutide. Now, this is already used for type 2 diabetes. And so obviously we know it's got a good profile for use in humans, but it's suggested that actually this can help with mild cognitive impairment. Now, but I think what we don't know is whether or not that this drug will help in people who don't have that cognitive impairment. What about if we give it to people who are healthy, but I mean at the moment probably obese, but what about people who are just healthy? So there's two trials going on called Evoke and Evoke Plus, and they're looking at the effect of semaglutide in people with mild cognitive impairment at the moment. And the Evoke Plus trial, and this is really encouraging to see to me, contains participants with significant small vessel co-pathology. One of the things that trials are quite bad at, or that we don't do in trials, is look at kind of relevant co-pathologies, because you don't want to kind of muddy the waters. But I think that people have to start thinking about doing that, because we're all humans with all of our various illnesses and comorbids. But I think that these trials now read out, I think it's next year, which will be really interesting thing to see. And even more interesting to me, of course, is what they're going to look for in the endpoints. I mean, obviously, they're going to look at cognition. This is what the trial's for. And so we want to see if we can, people with mild cognitive impairment, we can slow down or perhaps even stop that descent into dementia. But one thing that and I think, yep, that's it. They're looking at exploratory endpoints. So they're looking at the proteins that we in my lab investigate every day, and to see if we can see a change in these biomarkers and what that means for cognition, which I think is really exciting. And one thing I've always wanted is for people doing trials and drug companies to actually help let us be involved in these exploratory endpoints, because we've got the expertise to be able to kind of interpret that. And as I said, are we already doing a trial on healthy participants? Are the people who do not have type 2 diabetes but are now buying weight loss drugs on the internet, are these people actually gonna improve their kind of cognitive health through their life? How will we tell that? I mean, will it be that suddenly people stop getting dementia because they've been taking these drugs? I think that's something that we're going to need to wait to find out. But anyway, other dementias, it's much harder to find out detailed trials of drugs on other dementias, partly because accurate diagnosis is a problem. And that's obviously something that I'm really interested in. There are trials going on for drugs in LBD, FTD and ALS, but I feel like there's less disease-modifying trials in these ones and more symptomatic treatments. But since AD has been such a high in the news and such a highlight of the new drugs lately, I think it's causing a lot of momentum, and hopefully that momentum will trickle into actually research. And also genetic therapies in those diseases, those other dementias where there's a genetic cause, are being very, very much looked at. And we're looking at ASOs and like things like that at the moment. So there's a lot of brain power going into that right now. And basically, yeah, that's my kind of introduction, my wide overview. So I'm going to unshare my screen, hopefully. Stop sharing. And thank you for listening. Yep.
Perfect. Thanks, Amanda. Really nice overview. It's interesting and quite exciting to see not just the variety of different types of things that are in development, but the fact that, especially down the bottom end of the graph, quite a few are in phase 3 clinical trials.
Absolutely.
Which means we're getting towards potentially some more big breakthroughs. Now, what I'll do now is I've got a couple of questions before I move on to Aisha. So to anybody watching as well, if you do have questions, we have space for that at the end. But please feel free to drop them in the chat at any point. If a question comes to your head, pop it in the chat and we can come to that towards the end. And if you're watching this on playback, because quite a lot of people do, if you have any questions as well, I'm sure that the two speakers would be happy to be sort of reached out to, especially if it's, you've got a burning question about a particular drug. If they can answer it, I'm sure they will. So I've got my first question is around sort of fluid biomarkers, and we saw, I said this at the start, we saw headlines yesterday that we've got record rates of diagnosis of dementia, and that sounds quite scary. But at the same time, if you think of it from a more balanced perspective, is it actually a marker of us improving diagnosis? Because our diagnosis rates are 3 times better than a lot of other high-income countries. And I wonder if that's partly, as we develop more technologies around biomarker discovery, how do you see the role of fluid biomarkers evolving in the context of neurodegenerative diseases and diagnosis over the next 5 years? And could the development of technologies like this explain the fact that it's going to look worse before it gets better, because suddenly we're identifying more and more patients, but perhaps that's a good thing?
Yep. I think that actually, I don't think the rates of dementia or anything have changed. I think that people see more reason to get a diagnosis now. There's still a stigma, certainly, and that has taken a long time to change. But also, why would you get diagnosed if you can't do anything about it? And how many people go to their GP and they have memory problems, etc., but then nothing happens that's recorded and the person just, carries on. But I think, and I kind of know this from people reaching out after there's a newspaper article about blood biomarkers, that people are now there's understanding it's a disease rather than, it's actual disease rather than just a consequence of being old. Understanding that there are treatments on there are some treatments now available, not in this country yet, but it's potentially very soon that will happen. And they want now, perhaps earlier, they will think, oh, I should go to the doctor, I should get diagnosed. And we've now, for us, we know very well that there is a candidate biomarker for amyloid plaques in the brain that works really, really well as CSF or amyloid PET. And that is a start, isn't it? Because if we can tell someone's got amyloid in their brain and they've got cognitive problems, we really have a good start for that diagnosis. So, and we're really working on the other dementias as well, because we know that, the drugs, the monoclonals, they're not going to be given to someone with, I don't think, Lewy body dementia or Parkinson's dementia. So there's an impetus now and some very good grant programs starting that will address the other dementias. And with the use of the technologies that we have today and super sensitive technologies, we will be trying to tease out how best we can find those people as well.
Yeah, that actually answered my second question about sort of clinical applications and other dementias. It's a topic that's always fascinated me, because it is often a diagnosis problem. The earlier you diagnose people, the better the chance you've got of helping them, because at the moment they're diagnosed, they're too late, aren't they? Which is devastating for anybody who's affected. So I think what we'll do is we'll move on to Aisha, who's got some slides to present. Amanda, we're going to come back to you again at the end when we have a more general discussion, and we'll involve you both then. But Aisha, it's now over to you if you'd like to share your screen and talk us through some of the stuff that you'd like to present to the audience today, please.
Yes, sure. Please let me know when we start seeing my screen.
We can see the screen, yeah.
Can you see it?
Yeah, we can see that. Perfect. Thank you.
Okay. So, first of all, good afternoon, everyone. Thank you for listening. And we are here to present current treatment for Alzheimer's disease. But before diving right into treatment, we need to do a little revision of pathogenesis of Alzheimer. So this is our brain, and which consists of billions of neurons. And if we have time to count these neurons, there are 8.1 billion neurons. And this is the structure of a neuron, which consists of dendrites, which is a Greek word for tree, because it has branches just like tree and surrounding a cell body. Then we have axon, which is our highway, neuron highway, and axon terminates here, so we call it axon terminal. And the general function of neurons is to communicate, to send information, and to receive information. And as I memorized it, A is for away, and so axons send away the information. Dendrites do the exact opposite, which is receiving the information. And they do this through these tiny spaces, which is known as synapse, and in the form of these chemicals known as neurotransmitter. So in the cell body, there are vesicles, and usually very good things are happening in these vesicles, which are recycling. But sometimes there are bad things start happening in these vesicles, which may be due to many factors such as aging or genetic variation. So this is the structure of a vesicle, and as we can see, there are these pink amyloid precursor proteins. So there are like two scenarios here happen in this vesicle. Number one is these amyloid precursor protein are cut down by this enzyme, which is known as alpha secretase. This is the good scenario in which this amyloid precursor protein is cut down into small pieces. These pieces are harmless for brain and they do not clump together, so they are easy to get rid of. But the bad scenario is when another enzyme come along, which is beta secretase, and it cut down this amyloid precursor protein into amyloid beta. And a little bit of amyloid beta is actually good for brain. There are evidences to show that a little bit of amyloid beta helps in the development of axon terminal and also helps in the normal function of axon. But problems start when it starts producing too much of amyloid beta and they start clumping together and neuron is unable to pull it apart or break it down. So these amyloid beta then start accumulating in the cell body in the form of amyloid plaques, and it may take up to 20 years before the first sign of dementia are apparent, such as confusion and memory loss. And eventually what happens, neuron lack communication, stop communicating well, and also it may die eventually. And as we age, our ability to replace neurons lessen. So the problem starts here. So apart from neurons, there are other cells in our brain, such as astrocytes and microglia. When this accumulation of amyloid beta is happening, it can build up in the form of amyloid plaques, and it can kill neuron on its own. But here, what happens? Our neuron starts to exocytose these plaques out of the cells, and here immune system comes to rescue, and or astrocytes and microglia try to clean up this mess in the early stage of Alzheimer to a little extent. But with the time, the ability of microglia to phagocytose these cells lessen, and it is unable to clear this mess. And these plaques are sensitized by receptor outside the immune cells, which are usually told like receptor 4. And as a result, what happens? Inflammation begins, and this lifelong inflammation is associated with Alzheimer's disease. And this is exact the mechanism of monoclonal antibodies, which is our topic of discussion, which are current treatments. What they do, they actually clean up these amyloid plaques through microglia function or by stimulating or activating microglia. But the problem is we don't know if they only phagocytose, these activated microglia only phagocytose the amyloid beta plaques, or they can even eat up the amyloid beta protein or tau protein. This is actually monoclonal antibodies have the similar function. All the approved monoclonal antibodies have the similar mechanism of action, but the difference lies in their target. For example, there is Donanemab, and it targets the high molecular weight amyloid beta plaques, and then is Lecanemab, which targets protofibrils. Then we have Donanemab, which targets pyroglutamate. So their targets are different, but their mechanism of action is similar. First of all, we are going to look into Lecanemab, which is a very promising agent, and it is actually a humanized immunoglobulin G1 antibody, monoclonal antibody, and it is obtained from mouse. And it targets protofibrils, as I mentioned earlier, and it is administered to. It is actually indicated in the patients with early Alzheimer disease and with patients with mild cognitive impairment or mild dementia, and also who have evidence of brain amyloid beta from amyloid beta plaques from amyloid PETs or CSF studies. And it is administered intravenously, and its dose does not need titration in a weight-adjusted dose of. It is given in a weight-adjusted dose of 10 mg per kg bi-weekly, and it has been approved by FDA in Japan, but it is under review for European Union, United Kingdom, South Korea, and Canada. Its preclinical, it was in 2001 years birth, and his fellow colleague clinically recognized amyloid beta protofibrils as the pathogenic mechanism for Alzheimer's disease, which led to an early onset of Alzheimer's symptoms in mutation carriers. And it is found that monoclonal antibody 158, originally developed to detect amyloid beta plaques, reduce both soluble and insoluble protofibrils, and if administered early in the disease. The clinical trial was designed to assess the safety, pharmacokinetics, effect on plasma and CSF biomarkers, and there were some promising results. It showed slow decline in the clinical dementia rating by 0.45 points, and there were also significant decline in other cognitive measure at 18 months, and also there were amyloid PETs demonstrated that there were removal of amyloid beta plaque below the threshold for detection in 81% of participants. The side effects are usually infusion-related side effects, and also the very common side effects related to these lecanemab or any other monoclonal antibody are bleeding in the brain, or which are known as abnormality related amyloid-related imaging abnormality, and this may be due to edema or due to hemorrhage. Next, we have Donanemab, and it is also a humanized immunoglobulin G1 antibody, monoclonal antibody, and it is also obtained from mouse ME28, and it targets protofibrils. And its indications are also same as of lecanemab. It should be given in earlier stage of Alzheimer's disease, and its preclinical trials showed that it significantly reduced amyloid beta plaques in the dose-dependent manner, and there were no microhemorrhages observed. Clinical trials were designed to see the safety, tolerability, efficacy, and all cohorts demonstrated reduction in cerebral amyloid beta plaques with sustained response at 72 weeks, and there were similar side effects or adverse effect observed with donanemab as with lecanemab, which was amyloid-related imaging abnormality due to edema or due to hemorrhages in 26% of the subjects involved in the clinical trial. So these are very promising agents, but there are some downsides of these agents, which are their side effects, as these side effects are very lethal, which are usually bleeding in the brain, and we need a constant monitoring or MRI scanning to observe these side effects. And also 3 out of 850 subjects who were involved in the clinical trials died during the donanemab clinical trials. So some critics also call these drugs as dead end. And these drugs are administered to patients who are in the early stage, and for the early stage of diagnosis, patients require either the PET scan or either the lumbar puncture, and only 2% of the patients are having this gold treatment. COVID has a great impact on the dementia diagnosis. I was reading some reports which were related to COVID and dementia. So NHS England says that the pandemic had a significant impact on dementia diagnosis rate. I was reading a report yesterday, as you mentioned, Sam, that it was the report on the Independent that England has one of the highest dementia diagnosis rates in the world, with high income countries typically in the range of 20 to 50%, according to NHS. And here is an example. Paul, 73, from North Yorkshire, first started noticing his loss of memory a couple of years ago, and it has since got worse. He was referred for a brain scan by his GP and then waited 5 months for an appointment. And till Feb 2024, he still did not have a formal diagnosis. So what is the future of these drugs? Lecanemab and Donanemab target one of the causes of Alzheimer rather than treating the symptoms, which is a step forward. However, their effectiveness depends on early diagnosis. And for early diagnosis, as I mentioned earlier, that only 2% of patients are having this gold standard of diagnosis. And we hope that there will be, in 5 years, there will be a blood test to detect amyloid levels. And but still we have to wait for this. And Lecanemab, which is also already licensed in US, it costs about £20,000 per patient per year, and it is expected to approve in UK this year. However, there are 50,000 to 280,000 patients which will be eligible for this new treatment, and it will cost NHS from delivery administration of this drug from £500 billion to £1 billion per year. And even if the drug are approved, Alzheimer's charities say that NHS is unprepared for their delivery, and they have to do this cost-benefit analysis, and they have to review that either they should spend this much money and either the benefits of drugs are really worth it. So thank you so much. This was all from my side.
Thanks, Aisha. That's a nice and quite uplifting summary as well. It seems similar to what Amanda showed earlier. Like, we're sort of almost on the cusp of maybe even an explosion of treatments. So you talked a little bit about Lecanemab, which is the one that probably most people will be interested in because it's perhaps the one that's going to be at the UK, into UK hospitals the quickest. So do you almost see like a marriage of the two technologies, blood biomarkers to improve diagnosis, and then get a drug like Lecanemab in when it's most effective? Because are we almost too soon to get this approved, or do you think we can diagnose early enough to get this and actually be effective in patients?
As we can see that it is only given, it can be only given in the early stage of Alzheimer. So diagnosis, if our system is not efficient enough to diagnose the patient at early stages, if someone is getting their appointment of 5 months later, and their situation is declining every day. So I think these drugs are not as useful as they can be if we improve our system and make it more efficient. So yes, diagnosis is the key, is the first step. Once it is improved, once we have such a biomarker which will improve it, then these drugs are really useful.
Yeah, so I think what we'll do now is we'll open the questions to you both now. Because I think now's a good time to have a nice sort of open discussion. If anyone's got any specific questions, please do drop them into the chat. So I think a point Amanda touched on in her slides is getting people to understand, and this is improving now, that it is a disease and not just a normal, in inverted commas, part of aging. So Amanda, I'd like to come to you first and ask, what steps do you think could be taken to increase public awareness and understanding of not just dementia as a whole, but also the new advancements in treatments and what that entails? And you're currently muted, Amanda. So.
Yeah, good question. I think that perhaps in my mind, we need to look first at the people who will see those populations we need to get the message to. So this is primary care, really. I feel like, something that I think would be a good idea, this is obviously just my own opinion, nothing else, is like dementia specialist nurses in more places, so that the people who actually have the time and the expertise to talk to people about their possible diagnosis, because from what you were saying before, we're nowhere near ready for people to be going to their doctor's surgery asking for a drug to treat dementia. We're just not there. But I think that we could build a better infrastructure so that people can be made more aware of what their dementia is, what dementia is, how. I mean, that would be, so primary care would be a start, who are already, as we know, under the huge amount of pressure to see anybody. So, and I don't know what the answer is to that, but we can't tell people that we can diagnose them with a blood test and then not be able to kind of facilitate that.
That's
with
a
the
good
people
point.
we've got. So that's kind of my take.
Aisha, I saw you nodding a lot there, especially when Amanda mentioned the idea of more dementia specialist nurses. Obviously, you work in a hospital environment. Are you having similar thoughts about how we could address this?
Yes, my thoughts are actually similar, and that's a very good idea. But there is a lot of things are happening, and to having those nurses in the hospital setup, and it just needs more budget and it needs more time. I think idea is good, but to implement this idea, it will take a lot of time.
Yeah.
A lot of time, but perhaps time well spent as well. I mean, this is such a big issue that I think it almost needs a step change in policy as well, because clearly the current the current setup we have, where you talked about it in your slides, the NHS estimating that even if these drugs are rolled out, they don't have the capacity to actually get them to patients. So this needs a big shift. And before we get too far into the politics of NHS funding and that kind of stuff.
If these drugs are having more side effects, then NHS is spending more money, and then it will be burden on NHS if they are side effects like bleeding in the brain. Then they have to deal with a lot more. Then there are more bad consequences than the benefits. So
that's interesting. What you can say, Amanda?
I was just going to say, I feel like this is like a silent pandemic. We saw what happened when the non-silent pandemic happened. We weren't ready at all. And now that, I don't know if people were thinking that there'd never be any, treatments available. And so we just continue not doing very well. And now all of a sudden they're on the horizon. But I do think that there is, and there has been a commitment from the new government, that it will stand by the funding that it's already putting into accelerating these things. So, I mean, at least there is that, I suppose.
And this is only the first wave of treatments as well. So, if you make anything for the first time, it's never good as the 10th time. So, I think it's exciting to even have a starting point to be talking about. So, again, I'll a question for you both, and I think we'll go to Aisha this time for the first answer. So, obviously, again, I'm leaning into you here because you're based in a hospital environment, and so you probably see, certainly more than I would as a lab-based scientist, the impact from the clinical side, not just on the patients, but also the families that are supporting them. I mean, we've probably all got a personal experience of this. Pretty much every family's had someone who's struggled with dementia. But if you start to roll out successfully these treatments, and we see improvements in patients, how big of an impact does that have on the families? That's surely another angle we must think about as well. Not just the patients themselves, but the people the support network around them as well.
Here I'm sharing my personal experience. When I got married in Pakistan, we live in joint families. So my husband's aunt was living with us, and she was like around 80 years old. And at the time of when I got married, she was just diagnosed with Alzheimer's disease, but it was quite late at that time, and she died within 6 months. And within that 6 months, I saw her condition was declining badly from day one to till the time she died. So I think early diagnosis and is because she started showing symptoms very late. The confusion, the loss of memory, it was very late, at the very latest stage of Alzheimer. Maybe we were unable to sense those things earlier. It's just as a family you feel helpless, and it's just like, oh, what is happening, or what happened, or we were not able to see. And so I think if we implement such earlier diagnosis in our hospitals, in our systems, it will help a lot. It will help family members a lot to deal with such pressure, because uh, Alzheimer dementia patient has a disease progress, the patient is unable to take care of themselves. And sometimes they are on diapers, and you have to do everything for them. So if there is an early diagnosis, the family will be prepared for these kind of changes in advance. So yeah, it will have a huge impact.
Yeah, it's a nice point. Anything to add to that, Amanda?
I was going to say, I guess, I mean, that's really sad and unfortunate, isn't it? Such a late picking up of the disease and then a really quick decline. But I think that in the future, when we've got drugs that we don't have to infuse, that we can just give, orally or something, then maybe a dream would be to see people at 50 get their phospho-tau measured, for example, and then monitored from then on. We do it for plenty of other diseases like bowel cancer and breast cancer and what have you. And then we are able to give a treatment to somebody to prevent them getting that buildup of amyloid in the brain or whatever. And to do that, though, we need to do trials on healthy people. What happens if we give someone without amyloid in their brain a drug to remove amyloid? So maybe we'd be moving on from those kind of treatments because those are trials that haven't been done yet, but obviously would need to be. If you look on the chart that I put up, the people in the phase 3 trials for the biologics are all they've all got signs of that. I mean, that would be an entrance exam, would be amyloid in the brain or something like that. But like to be able to like monitor people from late middle age on and perhaps treat them with something that will stop it ever getting to the point would save so much money, wouldn't it, in social care, even alone?
Yeah, definitely. And it's like, so we've got a little bit of feedback, a comment saying that lots of people are going to love to watch this session back as well, because it's finding a super insightful discussion. So thanks for the feedback. So I want to stay on the therapy front again. This might be a strange question. It's almost like picking your favorite food, but is there, and I'll go to you first, Amanda, is there a trial that's going on at the moment, or a particular drug that's making its way through? It might be in phase 1, might be in phase 3, where you look at how that works, how that could act, and you think that is a potential game changer? I mean, they're all game changers really, because up until the last couple of years we had nothing to help patients. But is there a particular thing that really excites you, that you think, you look at that and think that's going to be a big step change?
Well, probably the thing that, bearing in mind, I don't know all the drugs that are in trials. I know a little. I mean, the GLP-1 agonists, to me, look really exciting. But I think, I don't know if I've been caught up in the newspaper reports, but they seem to cure everything. Addictions and obesity and stop you getting dementia. But wouldn't it be amazing if they did? I mean, I think that would be... I mean, and it basically is improving your metabolism, I suppose, which that's not rocket science, because it's what we know. You exercise, you eat well, you keep your blood sugar in check, and it is good for you. So I suppose, though, for the generation that we are today, not hunter-gatherers, maybe we need an answer like that.
Yeah, I do think it is quite exciting, and it's that thing that could it cure everything?
Yes.
It's quite exciting. What about yourself, Aisha? Anything in particular that you look at and think that's exciting?
I think when Amanda mentioned GLP-1 receptor, GLP-1 agonist, it actually excites me a lot because my thesis was on computational biology, and we were like finding GLP-1 receptor agonist. We were doing the computational thing for that, but throughout my thesis, I never learned or heard anything like this, that it can also cure dementia or Alzheimer. So it's like pretty exciting for me because it is something that I've studied and I want to study it more now.
So GLP agonists universally, everyone's excited about them. So I think, I mean, this is a topic we can sit and talk about for hours, but we've only got it for a limited time. And I think it's important to end on quite an important question when it comes to any form of research, which is money. You know, research costs money, so we need large sums of money to fund it. You know, clinical trials are tens of millions of pounds. And so, Ayesha, I'll come to you first. Is there a particular area of dementia research? It could be, you know, caregiving, it could be support, it could be blood biomarkers, it could be amyloid beta aggregation inhibitors, it could be GLP inhibitors. Anything that you think is in particular need of more funding at the moment? You think if we had a bit more money here, it could make a big change as well? Is there anything particular that springs to your mind with that?
It may sound biased because my area of research is computational. So what I think is to develop a neural network or a computational model that will help in the diagnosis of Alzheimer, and that will help in the early diagnosis of Alzheimer just by looking at neuro images. I think if we will be able to do this, it will be a great help for NHS and for everyone.
Yeah, I think that's a, and you know, we're stepping into an age where computational power is getting used more and more.
Yes,
we're seeing the integration of AI.
Take off a lot of burden from NHS if we will be able to develop such advanced models. It will be of great help.
Yeah, definitely. What about yourself, Amanda? Anything where you think in particular?
Obviously, I should say biomarkers, shouldn't I? I should say all the money should go there. But one thing I really like about the DRI setup is the care and technology part of it, because it's all very well saying, talking about diagnosis, and it's really, really important. But there are, is it more than 800,000 people living with dementia already who are not going to benefit from any drugs we do, that will, unless they're symptomatic treatments. But they're like enabling people to live better lives with dementia, and for their carers as well, because I think that's a really important aspect that is massively I mean, families massively contribute to the care in this country and don't get anything for it. So to make it easier for them, I think would be, I'm thinking about me, you know, like my poor husband's going to have to care for me surely in a few years' time. So we need that funding.
And I think the important thing there is when we talk about funding is it needs that collaboration between the private sector and, you know, universities and research groups need to be collaborating with industry and that kind of stuff, because these things do cost tens of millions of pounds, and there's not really many £25 million grants out there. You need to partner with industry, and so it's how do we drive that forward as well? And I guess that's another big focus as well. I mean, is that a big part of the work at DRI, is trying to build those industry links as well?
I mean, there's a big initiative at the moment for dementia trials, which we do not do well in this country. Actually, I'm not going to say we don't do them well. I'm going to say we don't do enough of it. There is not enough. There's not enough focus on funding it, because they're incredibly costly things to run, and to get them right and designed right, it's like no kind of like insignificant thing. And I think that definitely we need to be a place where we can do trials, and so we get those pharma companies developing the drugs to give to us to try, you know, to act in the trials, and that involves a lot of diagnosis and biomarkers as well. So that makes me happy. So,
and hopefully, Aisha, that'll lead to you seeing more and more trials coming through hospitals like the one you're at as well. So maybe the future is starting to look bright, you know, for the first time after decades of tireless research. So I think that's a nice sort of positive light to end on. You know, it's not all doom and gloom, and the news often focuses on the scary side of dementia, but there's a lot of exciting work occurring. So I'd like to finish by thanking you both again for joining us today. It's been a really insightful discussion. Thank you to the people that watch live, and thanks to anybody who's watching this now on playback. If you do have any other questions, please do reach out, and we'll see you all the next salon. Thank you. Have a good day.
Thank you, Sam, for hosting so well.
Thank you.
That was brilliant.
Thank you. Yeah, have a good day, guys.
Okay, bye.